Hello, welcome to the podcast Spinal Moves, a Canadian series about activity-based therapy, an intervention used to improve recovery for people with spinal cord injury. I am your host, Anita Kaiser. In today's episode, Hope and I will be speaking with three guests, Dr. Sukhvinder Kalsi-Ryan, Dr. Andrei Krassioukov, and Dr. Adalberto Loyola-Sanchez to learn about transcutaneous and epidural stimulation and how they can be combined with activity-based therapy to promote neurorecovery. We will also learn about the CONCENTRIC model and how it can guide implementation of activity-based therapy across the healthcare continuum. Our first guest is Dr. Sukhvinder Kalsi-Ryan. Dr. Kalsi-Ryan is a clinician scientist in the field of upper limb assessment and recovery and spine pathology at Kite Toronto Rehab University Health Network. Her research is oriented to establishing methods to quantify neurological change after injury and studying neurorestorative methods to enhance and optimize function for those with neurological impairment. Dr. Kalsi-Ryan is a principal investigator of the Upper Extremity Neurorestorative Innovations Lab and lead of the Rocket Clinic in Toronto. She is the founder of her own company, which manufactures the Grasp. Welcome to the podcast, Dr. Kalsi-Ryan.
Well, thank you for inviting me to speak in the podcast, and it's a delight to be here.
So you've been working in the field of upper limb rehab for many years. You lead the Upper Extremity Clinic and have developed your own clinical tool for measuring hand and arm function. So how has upper limb rehab and prognosis of recovery for people living with spinal cord injury evolved over the years?
So I'd like to say, to start with, there's probably two elements of change that have occurred over the years. And, we often hear the comment made that more and more people are walking away from spinal cord injury, which is actually quite true. And the reason we're seeing that is there's been an increase in the number of injuries that are incomplete in nature, and therefore giving individuals to have more recovery than just stable status after injury. What that meant for us as a field, though, was as the injury and the way patients recovered over time began to evolve, we also had to understand that a little better. So I would say one aspect of the evolution has been our understanding as clinicians and researchers of what recovery looks like for individuals that are less and less complete in nature. So we have very much established probably a strong understanding of that recovery profile over the last few years with use of more sensitive outcome measures, one of them being the Grasp. So that's one element of what's evolving. So how the patients present to us has evolved. And then in unison or in combination with that, opportunities to treat these people has evolved. So instead of focusing on a compensatory behavior or teaching someone how to do a task with intact muscles, we actually have the opportunity to take a look at muscles that are partially innervated or maybe paralyzed completely and see if we can restore function. So our rehab approach has really evolved in that we really look to enhance the recovery and restore sensory motor function. And then when we seem to have reached a plateau with a recovery opportunity, we can then move into applying some of the compensation type rehab opportunities that we've established in the past. And so basically what we have is a two-pronged evolution that's occurred. We have had patients that are changing over time, and how they present or how the disease presents to us has changed over time. And as such, we've also started to evolve our rehab practices to address those needs in disease change.
So that's exciting. So there's been quite a number of different areas that evolved and changed over the years. And, one area that's received quite a bit of attention recently has been neuromodulation. And for those of our listeners who's unfamiliar with the term, neuromodulation encompasses a number of treatment modalities that involve the stimulation of nerves that lead to a modulation or change in nervous system activity. And hopefully that changes in the form of neurorecovery. And I know one of these treatment modalities is transcutaneous stimulation. So can you describe for our listeners what transcutaneous stimulation is and how it works?
So I'll start by just commenting a little bit on neuroplasticity. So neuroplasticity is a phenomenon that we've had a handle on since probably the early 1900s. And the question that rehab specialists have always asked is, can we influence an individual's plasticity post-injury, or so after there's been an insult or deterioration to the neurological system? Can we have a hand in maybe driving how this neuroplasticity happens? And so one of the most robust tools to target neuroplasticity for the clinician is actually neuromodulation. So whether that's invasive or non-invasive neuromodulation, it actually becomes an incredibly powerful tool for us and for the patient to try and enhance or drive or maybe direct the plasticity that's occurring in the system. So that's the whole concept of neuromodulation. So with respect to types of modulation or neuromodulation, there's invasive and non-invasive. Invasive would be a device that would be implanted, such as a deep brain stimulator or an epidural stimulator. Whereas non-invasive is a type of stimulation that actually a therapist can apply with electrodes over the skin or over other structures of the body. And in some cases, we are stimulating the tongue now so that we can have access to the brain. So transcutaneous stimulation is essentially an opportunity for us to apply electrical stimulation to the spinal cord and the nerve roots through the skin. And that's the concept of transcutaneous. So we're able to provide some electrical stimulation to alter the neurological system in a certain manner, basically through the skin. So it makes it a very easy, non-invasive process to be able to help target someone's deficit and see if we can enhance or drive their neuroplasticity.
You mentioned transcutaneous spinal stimulation. So how is that different from transcutaneous stimulation?
So transcutaneous, that word simply means through the skin. So transcutaneous would be referring to the skin. So you can do a number of different transcutaneous stimulations. You can do something called transcutaneous cortical stim. So that's applying some type of an electrode over the scalp, and it can stimulate some of the structures in the brain. You can apply transcutaneous to a peripheral nerve, where you would apply it over the skin and it would target the peripheral nerve underneath. And in the case of transcutaneous spinal cord, we are applying stimulation over the skin, but in the region of the spinal cord that we want to target.
Because I know that transcutaneous spinal stimulation has just been done more recently. What sets it apart from the more traditional transcutaneous stimulation that's been done in the past?
So if you talk about the past and what's available in our publicly funded healthcare system, the primary transcutaneous stimulations that are available are muscle. So you can stimulate a muscle through neuromuscular electrical stimulation. Inevitably, that also stimulates the nerve ending as well. So you can stimulate nerve endings and muscles, but you can also stimulate now peripheral nerves with the same type of situation, which a lot of people do. However, what's unique about the spinal cord is there's a lot of bone in the region, and it was never really understood fully if you could target that stimulation, if you put it over the spine, and would you get a response. But some of the work that's been done shows that you can actually stimulate over the spinal cord and you can see the activity in the nerve all the way down to the muscle. So that's the difference. It's just really where in the body you're applying the stimulation. So the transcutaneous piece is the same for every type of stimulation.
So when you're able to stimulate the spine, are you targeting like cervical spine, the thoracic area, lumbar, or does it matter which area, or are there areas that have a better stimulation connection where you're getting better outcomes or results through it?
First of all, you can stimulate any level of the cord transcutaneously. So unless there's some reason or contraindication to applying stimulation over a certain part of that body, you can apply transcutaneous stimulation to any level of the spine. In some labs and in some centers, they're doing a lot of lumbar or thoracolumbar transcutaneous spinal cord stimulation for restoring lower leg function or lower leg muscle function. And then there's quite a bit of research being done with the application of the same transcutaneous spinal cord stimulant in the cervical region or so in the neck to try and see if we can restore some of the function in the hands and the arms.
So what's some of the outcomes that they've been seeing through that?
So with respect to the cervical region, everything that's been done so far to date is all experimental in that it's either been done in the form of a pilot study or it's been done research in lab on a single case study. And currently there is one very large pivotal trial. When I say large, I mean about 65 patients just being initiated. So this is all still in the realm of research, but the findings are really intriguing. So they're applying transcutaneous spinal cord stimulation to patients that have had cervical injury, and then they're applying it in the neck region. They're doing a training program which consists of approximately 3 to 4 times a week for about 4 months in total. And they're finding that patients are getting a response with respect to increased strength in certain muscles, improved movements in their fingers and hands, the ability to do functional tasks that they weren't able to do prior to the therapy. And then they're having a durable effect, meaning 6-7 months later, they still have the benefit of undergoing that intensive training. So we are seeing some positive results, and these are all so far in chronic patients. I haven't seen anything reported in, less than a year after injury.
And are these individuals with complete or incomplete injuries?
So the majority of the individuals that have a good response to the therapy are incomplete, but that's both sensory and motor incomplete. There is some work done in complete injuries, and it shows that there's less of a response. There is one. The gains that are made so far and that we've shown to date are minimal or smaller. However, it doesn't necessarily mean they're not important changes because it's really very individual. What amount of change in a particular muscle or movement means to every certain individual. So although the gains are smaller, it doesn't necessarily mean that it's less important. It's just really a matter of, what it is and how it can be applied once you've made that gain.
Sure. And, even when I think about a cervical spine or a very small change in functional recovery can translate to a very large change in functional ability for that individual. So that's really exciting to hear. I'm curious, do you see a role in activity-based therapy as a combined approach with transcutaneous stimulation or transcutaneous spinal stimulation?
Mm-hmm. So I do. I see a real role for activity-based therapy to be one of the driving training approaches. So what we know to date is the following. If you do a therapy of some kind, and it's done for a long enough period and it's done intensively enough, meaning that there's a real effort being applied from the patient, and then there's a real push to make those exercises tougher and tougher for the patient, we know that there's an effect. So there's a benefit. So even if you're just taking a muscle that is already active, but you can make it stronger, so it might be able to do more, right? You're not giving them more muscle function. You're just increasing the strength of an existing muscle. So we know that exercise alone, done in a fairly intensified manner, will definitely improve that muscle. And we also know that when you apply neuromodulation in some manner or form, whether it's peripheral nerve, whether it's spinal cord stim, whether it's cortical stim, whether it's repetitive transmagnetic stimulation, that the effect is amplified. Okay, so we do know this. I would say for absolute sure in that the studies have all shown this. So I do think that anytime you're thinking about using an electrical device to enhance your function or improve you, that coupling it with the exercise is one of your most critical aspects of that program. Okay, so for ABT being a regular routine intensification of movement program will certainly be a great coupling with the neuromodulation in general. And so we know that.
That's great. So I know you're just embarking on a pretty exciting study that's directly related to all of this. Do you mind sharing what your study entails?
So the one study that we are actually involved with at Kite Research Institute is we are one of the 2 Canadian centers involved in the Onward Medical pivotal trial. So we will be enrolling up to 10 patients in Toronto who will be receiving an intensive physical therapy program for 2 months alone. And then we'll be adding in the spinal cord stimulation, transcutaneous, with the particular device that they've developed. So we'll be able to offer that therapy to a group of individuals in our catchment area that have cervical spinal cord injury and that are chronic or at least a year post-injury, will, along with Vancouver, be conducting that study. In addition to that, at Toronto Rehab or Kite Research Institute, we will be doing a similar treatment with a different device. We'll be using the MindSearch to provide the spinal cord stimulation and couple it actually with an ABT program. So we will be including some Asia A patients in our study. Whereas in the pivotal trial from Onward Medical, it's only open to incomplete injury. So we would like to say that we're going to take a closer look at the Asia A group and see really what are some of the benefits they can get. And just stepping back to a question you had asked. So one of the things we're seeing in these intensification studies, so a lot of the intensification of rehab studies are coupling some kind of stimulation to exercise. And what we're seeing, muscles that have presented as zero for a very long time, so absolutely no activity in certain muscles, are actually starting to have some activity. So the smallest changes that we're seeing are that, you're going from a grade 0 to a grade 1. So you're nothing in a muscle to a little bit of a flicker. So unfortunately, in the study, we're not seeing a gain in function, but we are seeing this gain, for the first time after maybe 18 months, 24 months of a muscle actually becoming active again. If we can activate a muscle that's been zero for a long time, what does it take to maybe get it to a little bit of a stronger grade?
Yeah, that's really exciting. Like, just from that perspective of what you're saying, jumping from like a 1 to a 2 seems a lot easier than going from a 0 to a 1. So you're starting with nothing and actually being able to trigger some sort of a response. That's got to be incredibly exciting, because from that point, who knows what the potential is?
One is that. And, I've been a physiotherapist for 25 years. And if a muscle is a 0, and it doesn't naturally get some activity in it over a certain period of time, it stays a 0. There's nothing I can do to ever make that muscle go from 0 to something. Because, with your hands and without stimulation, you can't activate that muscle.
That's exciting. And, I see this being something that people with spinal cord injuries get really excited about, because especially with transcutaneous stimulations, it's non-invasive. So thank you so much, Dr. Kalsi-Ryan, for your time. It's been a pleasure to speak with you and learn about transcutaneous stimulation. And we look forward to learning more about your study.
Thank you, Anita. That brings us to our next guest, Dr. Andrei Krassioukov. Professor Andrei Krassioukov is a clinician scientist and an internationally recognized leading expert in the area of autonomic dysfunctions and rehabilitation of individuals with spinal cord injury. He is currently a professor at the Division of Physical Medicine and Rehabilitation, Department of Medicine, an associate director and a scientist at the International Collaboration on Repair Discovery, or ICORD, at the University of British Columbia. Professor Krassioukov also holds an endowed chair in spinal cord rehabilitation research at the University of British Columbia. He is also a staff physician at the Spinal Cord Injury Program at the G.F. Strong Rehabilitation Center in Vancouver. He is a chair of the International Autonomic Standards Committee for the American Spinal Injury Association and the International Spinal Cord Society. Professor Krassioukov's research is focused on autonomic dysfunctions following spinal cord injury. He has published more than 300 peer-reviewed manuscripts, books, book chapters, and reviews. Professor Krassioukov's work in the area of spinal cord injury has been recognized through numerous national and international awards. Professor Krassioukov was inducted as a Fellow of the Canadian Academy of Health Sciences. Presently, Dr. Krassioukov is a president of the American Spinal Injury Association. So welcome, Dr. Krassioukov, to the show.
Welcome. Thank you very much for the invitation.
Yeah, great to have you here. So one of the hot topics relating to spinal cord injury is epidural stimulation. So before we get into how epidural stimulation and activity-based therapy work, could you explain a little bit about what epidural stimulation is and how that works?
First of all, spinal cord stimulation story going far, far back, many, many years ago. It started obviously in animals. There was a lot of research was done. Can we stimulate spinal cord and what effects we can receive? Either it will be motor responses or autonomic responses, which I'm interested. Epidural stimulation means we're putting some electrical device, electrode, above the dura. Dura, it's a very hard tunica that covered spinal cord. And this is a tunica covered whole spinal cord to protect it practically. So this is even though it's a surgical invasive procedure, but still electrode does not touch spinal cord itself, but located in a specific area of spinal cord, depending what effect we want to achieve. And previously, epidural stimulation was used for treatment of hypertension, elevated blood pressure, for treatment of ischemic heart disease, but most commonly for people with spinal cord injury, and presently what is clinically approved in Canada, it's a treatment of pain. So there is a very well-established Medtronic stimulator when electrodes apply to the lower lumbosacral area of spinal cord, and then depending on patient individual setup, will be specific parameters found in order to manage pain. This is so far presently approved clinical indication for epidural stimulation after spinal cord injury. However, hopefully we will talk a little bit more. Presently, we're trying to push this envelope further, and we want to try, and we're trying right now very hard in many laboratories around the world to see, can epidural stimulation improve motor function? Can it improve cardiovascular function after spinal cord injury, bowel, bladder, and sexual function, for example? Mm-hmm. It's probably another topic of podcast.
It's a huge topic, actually.
Exactly.
Yeah, so that was a great explanation. And I'm wondering, another sort of newer topic is transcutaneous stimulation. So I was wondering, how does epidural stimulation compare to transcutaneous stimulation for people who don't know?
Yes, that's a transcutaneous, what it means, trans over the skin. It's a non-invasive, no surgical procedure required. We're using self-adhesive electrodes applying to different levels of spinal column on the back of person. And then we're trying to find, again, different electrical parameters in order to send signals deep, deep under the skin, activate specific neuronal structure, which eventually will activate spinal cord. Mm-hmm. And we will receive, similar to epidural stimulation, motor outcomes, autonomic outcomes, including bowel, blood, or cardiovascular responses. That's the difference is only where electrodes positioned, surgical or non-surgical.
Mm-hmm, I see. So in some of the other interviews, we've discussed how activity-based therapy might not be possible immediately after spinal cord injury in acute care. So this can be for a variety of reasons, including mental and emotional readiness. One reason might be that ABT demands significant intensity. So for example, numerous repetitions, increased heart rate, increased duration of exercise. So many of your studies investigate cardiovascular function and different autonomic functions and how they can be improved for people living with SCI. So how has epidural stimulation affected some of these functions? And do you think this could prepare someone with SCI to engage in ABT?
This is a very, very good question. So one of the aspects for activity-based therapy, we do know we need a preparedness of individual of his or her cardiovascular system. If, for example, we will put individuals into the exoskeleton apparatus or into the Hakoma Lokomat or put on the bike, which will be moved with electrical stimulation, person health, cardiovascular health has to be sufficient to participate in these activities. Blood pressure cannot be below 60 or 80 because they will be fatigued, they will be tired, exhausted. And this is one of the limitations, what you mentioned, that in acute period, it's one of the limiting factors to put person with neurogenic shock when blood pressure is so low to participate in activity-based therapy. Epidural stimulation, right now, what we see from limited amount of either experimental animal research or clinical research could prepare individual with respect of cardiovascular responsiveness. We do know right now that we can activate spinal cord structures by epidural stimulation or transcutaneous stimulation and elevate blood pressure, and then maintain blood pressure during the changing from seated to supine to standing or from supine to seated position, that a person will have less what we know orthostatic hypotension or drop of arterial blood pressure when they're changing position. This allows them to function better. And actually, we just recently, one of my postdoctoral fellow published a very interesting study in neurology. We call this paper ergogenic effect of transcutaneous and epidural stimulation. If we increase blood pressure, person feel better, they can perform better during exercise. That's a question, answering exactly your question. Yes, spinal cord stimulation, either using epidural technology or transcutaneous applied technology, could prepare a person with spinal cord injury to feel better during activity-based therapy.
That's fantastic. That really is. So in one of your recent research articles, you described how spontaneous volitional movement occurred in individuals with chronic complete spinal cord injury with epidural stimulation, and it was actually sustained after the epidural stimulation was discontinued using conventional therapy. So could you tell us a little bit more about that research, and then how do you think ABT might potentially benefit these same individuals?
Right. That's right. As you know, numerous people around the world already demonstrated that even in motor and sensory complete individuals, epidural stimulation applied many years after the injury could elicit voluntary movements. It's a not novelty. Dr. Cortin showed in his research, Dr. Harkimer showed in her research. Research what you referred was obtained actually from Dr. David Darrow laboratory, with whom we're collaborating a great deal. He's a young, very enthusiastic and bright neurosurgeon who just recently started his independent neurosurgical career in Minneapolis. That's why it is exciting to see that after finishing session, after multiple sessions of epidural stimulation, there is some kind of memory, or what we call maybe synaptic plasticity, which is a component actually of also for activity-based therapy. If we activate the circle, which was silent or not functioning very well because of spinal cord injury, but we were able to engage this circle, and this circle became functioning again with a just small boost of stimulation. This is the most likely is a potentiation effect of epidural stimulation with activities that patient was involved during time that result in some persisting effect when stimulation is finished. But again, I would like to say, if we look around the world, we're talking about 20, 30 patients who presently are implanted within clinical trials. I'm not talking about patients who will go for implantation because of financial possibilities. And then they will come back with stimulators without well-designed follow-up and training, unfortunately.
Yeah.
But people who are involved in the clinical trials where we can document these changes, this is still we're talking about very limited number of people.
Mm-hmm. So one last question for you. So you did mention that you've been working with labs in Minneapolis, and you mentioned some other researchers throughout the world. So what do you think the next step is in bringing epidural stimulation to Canada?
So as I mentioned to you previously, it is already in Canada.
Yeah.
In Vancouver, for example, our neurosurgeons implant epidural stimulators for pain management, either people with spinal cord injury or with retractable pain due to other disorders. That's why technology is here. Neurosurgeons are ready. What we are not ready we have to show to Health Canada, similar to FDA in United States, that this technology can do something else. Mm-hmm. And that's why we're looking forward for outcomes of a few clinical trials that right now run by Dr. David Darrow in Minneapolis, or Dr. Cortin right now starting international multi-center study to improve hand function with transcutaneous spinal cord stimulation. As soon as clinical trials show efficacy, then we can go to the Health Canada and get clinical indication and approval that it will be part of clinical practice. But this is only step one. Mm-hmm. Step two, each stimulator, either implantable or non-implantable, costs money. Where this money will come, that's why our government, our Ministry of Health have to plan in advance when and how we can fund this a big investment for, unfortunately or fortunately, small group of people that, again, as you know, spinal cord injury is still considered a small disease. Mm-hmm. Another big concern for future, we have to be preparing physical therapists, occupational therapists, young physicians to be ready and to be familiar how to manage these either implanted stimulators or transcutaneous stimulators in clinical practice. There has to be put mechanism for billing system for these procedures of training. We have to develop a specific codes, how many sessions physical therapists can work with one person. Dr. Harkim are telling us 80 sessions at least. At the present time of our clinical situation in Canada and also in US, it will be not possible for every single person. So this is the situation. Then, of course, we have to educate our patients, caregivers. This is a totally different situation with respect, not just catheters, which in and out, for example, for bladder management. It's a sophisticated, complex technology. And this is, I believe, few issues which I see, despite the big interest, big excitement. I know that there were few news events related to implantation of epidural stimulation of patients with spinal cord injury across Canada who went abroad to implant it in Thailand. And of course, people are asking Canadian government, please support it. What is the next stages? And I'm totally in support of this idea. But again, as a practitioner working in a hospital and realizing where our resources are, it has to be done additional work by government, by Ministry of Health, and also by us scientists to make evidence strong that this is incredible and possible technologies that could be recommended and implemented to clinical practice.
Mm-hmm. Well, there are a lot of different parts, certainly, to bringing epidural stimulation in Canada, and thank you for bringing our attention to a lot of those. Thank you very much for coming today on the podcast for the interview, and it was a pleasure talking to you, and best of luck in your future research. I'd like to welcome our final guest. Dr. Loyola-Sanchez completed his medical and specialty training in Mexico City and his research training at McMaster University for both his MSc and PhD, where he was also a Vanier Scholar. He attended the University of Calgary for his postdoctoral studies, and he was a Banting Scholar there. Since then, he has been working on developing a program of research to design, implement, and evaluate community-based rehabilitation programs for people living with disabilities produced by chronic illnesses in outreach communities. This program has mainly focused on underserved populations, so Indigenous rural communities in both Mexico and in Canada. He is currently working clinically in the spinal cord injury program at the Glen Rose Rehabilitation Hospital in Edmonton, and together with Dr. Chester Ho is leading the CONCENTRIC project. Dr. Loyola-Sanchez is the new principal investigator of the Rick Hansen Spinal Cord Injury Registry at the Edmonton site and is leading a community-based initiative to increase the sense of community for people living with SCI, service providers, and family in the province of Alberta. This initiative is known as the Spinal Cord Injury Community of Interactive Learning Services. This work has led to collaborations with community services that focus on activity-based therapy. Welcome, Dr. Loyola-Sanchez, to the show.
Thank you. Thank you, Hope.
So in some of the early episodes, we discussed activity-based therapy across the continuum of care. So something that we haven't touched on yet is actually transitions in care. Can you tell us a bit about what are transitions in care and how can this affect individuals undergoing spinal cord rehabilitation?
Sure. So transitions in care refer to any set of actions or any activities that happen when a person experiences a change in the healthcare system. So that means when you, for example, you were healthy and then suddenly you had an illness episode, you went to the hospital, that is a transition. You recover your health at the hospital. So in case of spinal cord injury, you can imagine that these transitions happen all the time. So it starts with the injury, the transition to that, and then transition from acute care or the hospital setting then to inpatient rehabilitation in many cases, then from inpatient rehabilitation to community, and then in community, you have transitions. So you go to a family dog, then you go to home care. So all of those points are transitions. And these transitions have a particular set of actions embedded. So now the issue is always, how can we make those transitions appropriate? And that requires two main concepts: coordination and continuity. By coordination means that the place that you're transitioning from, it's coordinated with the place that you are transitioning to. Mm-hmm. And the other piece is the continuity. Once that transition is over and then you move to a new transition, there should be more communication back. And that has been incredibly difficult in the layout of the systems, at least here in the province of Alberta. Going back to your second question about how does this affect the spinal cord injury individuals? Well, they affect them very, very much. And we have new data showing that poor transitions are highly related with an increase in health issues. And by health issues, I mean, for example, more infections, more urinary tract infections, more pressure injuries or skin problems, more pulmonary infections, etc. Theoretically, that's the reason. Poor transitions create that sense of poor quality of care. Each of the points of the transition are doing the best job. The problem is that because they are not connected in an efficient manner, the patient and the health provider as well perceives that this is fragmented, and that fragmentation is ultimately perceived as low quality. That's why transitions, it's an important theme to look at and an important need to try to improve their quality.
Okay, so we've spoken to a number of people about the background of activity-based therapy and how they use it. And we've talked a bit about technology to deliver ABT. So one issue that always comes up that we were just talking about actually is access to ABT. So how can we access it? How can we access the healthcare to support it? How can we access technology or equipment? This is something that you and Dr. Ho, so you can listen to Dr. Ho in episode number 5. So you and Dr. Ho have been working on CONCENTRIC. Mm-hmm. So can you tell me a little bit more about what CONCENTRIC is and how is ABT embedded within that access model?
Perfect. Yes, sure. So CONCENTRIC stands for, is a research project that aims to improve the transitions in care for people living with a spinal cord injury in the province of Alberta. This is a research study, again, going back to my point of the transitions in care and the points of care, right? What we are assuming and what we're finding now is that, yes, these points of care are not connected. So the ultimate goal is to create a model so we can connect them and finally form this as a system. One of the main assumptions that we have is that maybe a model that is based on the hub and spoke system, it's going to be the answer. The hubs are considered the specialized knowledge, the spokes are considered generalized knowledge. So the whole point is to link hubs and spokes. For example, in Alberta, we have 2 main urban centers with specialized knowledge, or hubs. one in Edmonton, and one in Calgary. But we have at least 11 spokes, 10 to 11 spokes identified so far in the province, in which general knowledge is accumulating, but they are not connected at all. So the whole purpose of CONCENTRIC is to bring them together. Now, what is the connection with activity-based therapy and CONCENTRIC? And that's a very interesting question, because if we take the definition of activity-based therapy as any interaction or any intervention towards improving the health of the parts of the body that are below the level of injury, right? Like you can call it sensory and motor recovery, or the health of the bone or the muscles, whatever take you get on it. At the end of the day, that's what we want in activity-based therapy, right? This is a paradigm shift in the culture of spinal cord injury, right? Because before it was more like, let's focus on what works and let's forget about what doesn't work. And of course, that is a very biomedical vision in my perspective, because of course it comes from us, from health providers that say we cannot do much there, let's focus on what we can do. But of course, like people with spinal cord injury has brought this to our attention for a long time now. And I feel that's part of the big push that has allowed activity-based therapy to flourish, to be more seriously considered now. Regardless of the definition or regardless of the type of intervention that you put, it's all about intensity, right? It's high intensity intervention. If you don't have that, you won't get the results. So we need the buy-in of everyone who is in a position to deliver a service that could increase the intensity, right? So we have three main challenges. One is we need to integrate this evidence to what we're doing in terms of in the conversations we're having about what is needed from people to improve the transitions. And it's interestingly because we have a good justification here in CONCENTRIC during our stage 1. That has been one of the things. People with spinal cord injuries telling us loud and clear, I want to work on my neurological recovery as much as I want to adapt to my new life. And it's not only about the function, because a lot of people think activity-based therapy, it's about walking again, the miracle thing, right? The miracle result, which that will be nice. Of course, if you can get it, that's fantastic. But no, people with spinal cord injury in our interviews have been, I would say, more conservative in their expectations. And what they share is, I just want this for improving my self-image, improving my self-esteem, improving the health of my muscles and my bones, decreasing the risk of me having a pressure injury, because if you increase the muscle mass in your legs, for example, less risk of pressure injuries. So that's why we have a good justification for the step number 1, which is integration. So now only time will tell how much reception we will get from the stakeholders. Of course, this includes people with spinal cord injury, so don't get me wrong, they're going to be in the table. And of course, I hope that we will have these debates. The second is recognition, right? People in these hub and spokes sites need to recognize that ABT is worth it, that is real, and we need to invest in it. So far, I think I'm seeing cracks now in the way that the health providers are perceiving ABT. However, not enough for actually tell you, yes, for example, here at the inpatient rehab hospital I work with, ABT is part of it. No, I cannot tell you that. However, I have seen some individuals, and that's what I call them, the early adopters, right? Early adopters are open to it, they understand the need, and they started the conversation with their colleagues. And lastly, I think we need to use imagination. You touched it when you asked the question about access. So activity-based therapy could be done in many different ways. We should not limit ourselves to say it has to be epidural stimulation or it has to be a FES cycling. Because if you go to a rural area in Alberta where you don't have that available, then what? That means that you're done, right? So we need to have that imagination in order to create. If we find nothing, well, we can create, and if we have the money, well, that's great. We can bring all the technology that we want. But in the cases in which we already have something created, modify them and see how we can incorporate the principles of ABT to what we're doing. And that, in my perspective, will open the door to more technology development.
That's really interesting and some great ideas there, and definitely good points about ABT. So earlier in this episode, we talked about, and you just mentioned, stimulation. So we talked about transcutaneous and epidural stimulation. With epidural stimulation right now, if people with spinal cord injury would like this operation, they'd have to go out of the country. So thinking about the transitions in care, this puts this individual kind of more or less outside of the Canadian healthcare system. How do you think we can support them after they come back?
Yeah, that's a very good question. My perspective, as you know, I come from another country. I'm from Mexico originally. When you come from another country, it's interesting because you have a different perception of things, right? At some point, you're an outsider. And these gaze have allowed me to see that this issue with epidural stimulation is becoming political, and we are using science as our main media to reject or accept the idea of epidural stimulation. Yes, I think that current ABT centers should have a role to play in the continuing of care of these people that went abroad to get epidural stimulation. The other piece is that is not enough because, again, going back to my point of the culture shift, epidural stimulation, I see it under the category of ABT. It's kind of like, yes, it's very promising. We're seeing it. We're seeing results from other countries, but these countries do not have the legitimacy and validation that we would like in our countries. This is the divide between the developed and developing world. And it's kind of like assumption that we do the best. The rest of the world, the so-called developing world, is following us. So when you get, like, for example, these services in Thailand, and you look at the videos, I have been exposed that actually 2 of my patients here in Edmonton are considering going to Thailand. And now Thailand opened up a center in Mexico with a colleague of mine. So wow. We opened that center in Mexico with the neurosurgeons and all of that. But I at least what I do is I what to do with those people that actually went, do it, and came back. For the providers, we need to understand better about the parameters of the epidural stimulation, how to identify complications and side effects, and most importantly, how can we use the epidural stimulation to potentiate the neurological recovery, going back to the principles of repetition and intensity, right? That for me is a very important point that explains me a little bit of the hesitancy from the health providers, because we humans, we tend to reject what we don't know. So if you don't know enough, the easiest answer is to say no. So that's where you have the conflict between someone that already has it, already make the decision to go through the procedure, and then comes to your country, and then you need to help. And these people are facing those barriers. And this is not only talking about physicians, I'm talking about what we call allied healthcare professionals, right? PTs, OTs, they are not buying in. So the patient gets nowhere with the support that they need to actually potentiate the use of epidural stimulation. This is an issue of increasing capacity from the stakeholders. We need to understand more. It's good in a way that patients are doing it because they're forcing us to open our minds. And second, this is going to be a culture shift, and we need openness. We need to understand better what this entails. We need to trust a little more in our colleagues outside of our developed world. And of course, hopefully, we will have the science answers soon. There are trials, as you know, that are going on, that have been going on for years now, and hopefully we will get those results soon. None of my patients have gone through it, but if I get one, I will have to step up my game and support, right? I think that's the reaction that we need to have.
Yeah, I like your message of openness and being also open to other cultures and just accepting those patients and trying something rather than maybe trying nothing when they come back.
And you know what? That's a very good point, because at the end of the day, that's why my immediate response was yes to the ABT centers, because people doing ABT are facing similar barriers from the mainstream healthcare system. They are often say, like, you're selling false hope, this is not true, the science is not backing you. So they have a good niche in there. However, as we know, most of these ABT centers cost for the patient, right?
Yeah.
And second, again, going back to the transitions, that is a transition. You go into an ABT center, that is a transition. And right now, there is no formal communication between these centers and our specialized services. That creates a huge problem because people get hurt sometimes, or people are improving, and we're missing that. And we are missing the opportunity to learn that these things work.
Of course. So we have touched on access, but there is one more piece to access I'd like to address. So your research, among other things, has been focused on delivering access to individuals in Indigenous communities. These are arguably some of the most underserved communities in Canada with regard to healthcare access for many reasons. So how do you think that we can improve spinal cord rehabilitation amongst these communities, and do they fit into the concentric model for spinal cord injury? Can we provide them with ABT? What are your thoughts?
Yes, concentric has a specific arm for Indigenous health. So what we designed concentric, we acknowledge that the effects of colonization in North America have a very deleterious effect on the health of Indigenous individuals. So because of that, we acknowledge that if we go to a community and say, hey, here is what we're going to do, that will be reproducing this unfairness, reproducing these effects of colonization. So what we decided is to have a mainstream, let's call it mainstream concentric, in which we're doing all these interviews, but then we'll have a parallel arm for Indigenous health in which we're trying to engage with different Indigenous communities in the province. So with leadership at this time is to work with them and identify what is the best way to achieve what we want to achieve in the mainstream. Going to the question of does ABT or any intervention is going to be good for them? Of course, because they're human beings. Theoretically, yes. Now, culturally, though, that's what we need to understand. Those are still things that we don't know. Culturally, how those activity-based therapy will fit with their view of healing. With my previous experience working with Indigenous communities in Canada and in Mexico, I can tell you that they're very different, of course, but their views in health are really integrative, are really holistic. So it matches beautifully with the whole piece of concentric of like bringing everyone together, right? Mm-hmm. And also it matches beautifully with the idea of being open and respectful to others' opinions. So I think it's going to be a very good match. Right? I'm very optimistic that once we get the ball rolling in the Indigenous communities, one of the expectations is that we are going to work with elders or representatives of Indigenous knowledge so they can guide us on how their views on healing match with what we want to do. And of course, I need to end this reflection by giving the message of Indigenous communities are not a single entity. Canada has named them officially First Nations. They are nations, and all of them have their own rules and their own cultural beliefs. Yes, they have commonalities. For example, most of them have this holistic approach to health, which also includes the spiritual health. And that for me, it's not only includes it, it's in the center of healing. And that for me is a big difference because we don't have that necessarily. So this is going to be an interesting shift because if we don't get to the spiritual part, maybe we're missing a lot. The other thing is that talking about Indigenous health, we need to it forces us to understand health and healing beyond the body. And it forces us to look at the social and the cultural determinants of functioning and health. And that is incredibly nourishing for the mainstream society as well. Learning how to do this in the Indigenous field is going to benefit the other, like the mainstream society, because we need to apply that lens and that knowledge to all, because social and psychosocial and cultural determinants of functioning are there, and there will be no success in transitions. There will be no success in implementing activity-based therapy interventions if we do not consider the social, cultural, and psychological aspect of being human and well-being.
Of course. Well, thank you so much for all of your answers. And I think the common thread in this show is whether you're engaging in technology for ABT or stimulation, it's all about finding the appropriate intervention for the appropriate population. So Indigenous communities, we need to find the right fit as well.
I agree.
Yeah, so again, thank you for coming on to the show, and good luck with the rest of your research, and good luck with CONCENTRIC. Thanks for listening. On our next episode, Anita speaks with two guests on their experience starting ABT clinics in their communities of Edmonton, Alberta, and Toronto, Ontario. Speaking of tuning in, you can link to Spinal Moves and get more information about ABT at www.praxis.com. Or you can also listen to Spinal Moves on Apple Podcasts, Spotify, or other popular platforms. This series is brought to you by the Canadian ABT Community of Practice and is sponsored by Praxis Spinal Cord Institute, a Canadian-based not-for-profit that leads global collaboration in spinal cord injury research, innovation, and care. Special thanks to the Saskatchewan Centre for Patient Outreach. Spinal Moves was created by Hope Jervis-Rademeyer, produced by Hope Jervis-Rademeyer, Praxis Spinal Cord Institute, and Anita Kaiser. The information provided on Spinal Moves is of a general nature and cannot substitute for the advice of a medical or healthcare professional. The opinions expressed on the show are solely that of the host and individual contributors. None of the individual contributors, system operators, developers, sponsors of Spinal Moves, or anyone else connected to Spinal Moves can take any responsibility for the results or consequences of any attempt to use or adopt any of the information presented through this podcast.